I'd like to call this meeting to order, if everyone will rise with me for the Pledge of Allegiance. I
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Christine, would you please take roll call?
Director Danielson.
Present.
Director Wallace.
Present.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Epen.
Present.
We have a education session.
It's my pleasure
Would you
tonight
please?
to present to the board the staff of our hospital, volunteer services, and our community at large a very special educational presentation. Tonight you'll be hearing from Dr. Carmen Akawili and Dr. Kranti Achanta, two members of our medical staff and the leadership of this hospital that became involved in a very special international mission in the Philippines. I don't want to steal any of their thunder, but I would like to offer the following reflections. 6 of our nurses and many members of our medical staff went on this journey far from home without any expectation of being acknowledged or rewarded for what they've done. And they provided desperately needed services to a population that has been severely tried by the forces of nature. Their efforts represent the best of what being a physician and a nurse is all about. The generosity came right from their heart, and they worked harder there in a single day than they might have worked here in a week. I think what they've contributed to our world community is something of immeasurable value. I couldn't be prouder of them than I am, and it was just overwhelming to see what they did and how they accomplished what they set out to do. I think the Philippines owes them an enormous debt, and our hospital has immeasurable pride in their success. So with that, I'd like to invite Dr. Carmen Akawili to begin the presentation.
Thank you very much. Thank you very much, and good evening, everybody. As the president of the Philippine Medical Society of Northern California, I led a delegation of 170 volunteers in a medical mission in Bohol, Philippines. It was hit by a 7.2 earthquake in September of 2013, and then 2 months later, it was devastated by Typhoon Haiyan. As you know, this is the strongest typhoon ever recorded. So around 28 volunteers from Fremont, California came, and this was special because 15 mission volunteers from Washington's hospital came and supported me. They have volunteered their time, their money, and their skills, and helped the indigent people of the Philippines. So this is the Philippines, bounded by the northeast, by the Philippine Sea or Pacific Ocean, South China Sea, and below Malaysia. And we were in the Visayas area in the Bohol region. I don't have the pointer, but it's here. This is Bohol, and this whole area was devastated by Typhoon Haiyan. This is now Bohol, it's an island. So we started at the San Francisco airport. We had 40 boxes of medicines and some instruments with us, but before that we also had 40 more boxes. And we started our 16 hours flight from San Francisco to the Manila International Airport. We're still smiling after that. You see Dr. Achanta here, Dr. Brian Smith, Dr. Goni Sandu, and Dr. Halimi and his wife, Isa. I don't know where my husband is, but he's somewhere there. Then we waited 5 hours. So after 1 more hour of flight from Bohol to, from Manila to Bohol, that's an hour flight, total of 22 hours, we finally arrived. And we're tired, but we're all happy and eager to work. So these are our delegation again, smiling for the camera. And this is our 40-foot container that houses our anesthesia machines, our OR tables, all the other instruments we have. And it arrived about two months prior to the mission. So Sunday, we started work. This is the OR nurses filing their instruments, checking the instrument and supply. This is Brian again, looking into his drugs and anesthesia supply. And the room at the back is the place for medication. It's locked and guarded securely by security guards and, of course, the OB anesthetist. This is now our central supply. You can see Claire Johnson, Athena Albino, and Apollo, our ICU nurses, helping to unpack and repack the central supply room. And then after dinner, we have huddle. We have our schedules and we have our small meetings. This is the post-anesthesia care group. We have the ophthalmology group, then the security and traffic control group, and some were their outpatient. Then we started Monday. I'm gonna describe to you outpatient, and Dr. Achanta will describe the hospital work. In the outpatient, we use the Bohol Auditorium. It's the cultural auditorium. It's big, it has a stage, and we always start the day with a prayer that hopefully will be able to help everybody and no complications. Outside, 1 or 2 hours before that, we start at 8:30. We already have a lot of patients coming all over the different towns in Bohol, traveling from 1 hour to 3 to 4 hours. That's our triage. We have 2 paramedics and several nurses helping out. And inside, we stage it so that in the bleachers, we have the optometry department. On the left side, facing the stage, is the dental department, and the stage is the pharmacy, medications. In the middle is the pediatrics department, and on the right side is the adult medicine. This is the dental department, and you'll see on the stage the pill counter team, busy classifying and counting and bagging pills. This is Aisa Halimi, patiently counting the pills. And then we're also looking at the boxes of antibiotics, anti-diarrheal. Then on the right side is the internal medicine or adult medicine department. Here's our very dear Dr. Goni Sandhu, our GI consult, patiently examining the patient, and this is his examining room, makeshift one. Then we have our respiratory therapists volunteer also, giving all the nebulizer treatment to the patient. This is how busy it was the first day. A very impatient patient. And if you look, there's chocolate there given by some of the volunteers. Also, again, you'll see the chocolate in here. So they're patiently waiting. Of course, we cannot treat everybody, so we have a referral desk for minor surgery or some labs. This is Dr. Doris Rodora de la Cruz, our Fremont pediatrician, also came in. And this is our glucose point-of-care testing area. Dr. Prasad Kata, our endocrinologist in Fremont, donated around 250 of test strips and some glucometers. Thank you very much. Now our BC Dental Department. This is the pain relievers, Dr. Stewart. And this is their weapons of extraction. And we don't have any dental chair, but they manage to do it with coaching, I guess. And these are our brave patients, very brave patients. Now in the optometry department, we have Matthew Manchester from Alameda, who's our optician. And this machine, the refractometer, it was donated to us. And here they are, waiting to be graded, refracted. And this is the waiting area on the bleachers, watching all the rest of the patients in the auditorium. We also had one-on-one health education. We also have a nurse practitioner from UCSF that gave CPR class, showing the Heimlich procedure here. And we have Dr. Jose de Guzman doing health education to high school students as well as nurses. And this is our statistics team over here. with Fred Asilar. We have our printer here, and it's like control center. That's me and our very energetic mission coordinator, Dr. Celi de Guzman, and of course, my better half, who was always very supportive. And I just want to let you know that, I hope you can see it, but I'll just read it to you. For 5 days, major surgery, we only did 4 days. We had 66 major surgery. We had 124 minor, and ophthalmology is about 79, a total of 269 surgeries that 5 days. In the outpatient department, we had 2,815 adult medicine, 1,071 pediatric patients, point of care testing about 257, health education one-to-one was 169. We had 1,782 dental patients, and we gave around 1,300 eyeglasses, graded eyeglasses. So a total of 7,666 patients we saw that 1 week. So for the major surgery, chyloplasty, the cleft lip palate, about 11 of them. Then cholecystectomy, gallbladder surgery is about 7. Then hemorrhoidectomy, 3. Hernia repair, 9. Hydrocelectomy, 2. 2 mastectomies. I think one was breast cancer. OBGYN procedure was about 11. Thyroidectomies, about 19. 66 major. For the minor, 124 of them. And for the ophthalmology, we did have 59 cataract intraocular lens implant cataract surgery, 17 pterygium. And this is, the statistics team really did well and recorded all the number of patients we have seen. So Dr. Achanta, your turn. You can use this, by the way.
So I'm Kranti Achanta. I'm one of the general surgeons here at Washington Hospital, and it was definitely a life-altering trip for a lot of us. I've been on many previous medical missions, but this by far exceeds anything in scale and in the level of organization. A lot of credit goes to Carmen in how beautifully things were arranged. In fact, we got down. Most of us didn't know each other before. We all got together in San Francisco airport, and that's how we knew each other. And in one quick huddle, we all knew what our roles were, and nobody complained. We just jumped in and did whatever we needed to do. This is the regional teaching hospital. It's the governor's hospital. This is where most of our work was done, inpatient work. This is the operating room, or the sterile area. And the operating room has boards, the schedule, very similar to how we do our work here. The difference is, once we get into the operating room, we were given 3 operating rooms, but each operating room had 2 tables, where 2 surgeries, you can see 2 surgeries being performed side by side, 2 teams preparing, 2 anesthesiologists, everything, and you can see how little space there is. This OR was designed for 1, and so these 2 lights belong to one patient. So we split the lights, and we went to work. This is an example of what kind of cases we saw. This is one lobe of the thyroid. This gentleman had previously had one thyroid lobe removed at a previous mission more than 10 years ago. This is just one lobe of the thyroid occupying the entire neck. This is the equipment for anesthesia, and you will see that this anesthesia machine is out of a suitcase. So these were used in Desert Storm and other war zones for the MASH units, where they were parachuted in, and they've been repurposed and reused. This is the anesthesia work area. It's when we talk about tackle box, this is really a tackle box. These are the gases, and this is the workspace. This is Brian, and Brian's back. This is another anesthesiologist. They do not have ventilators. Once you intubate the patient, throughout the case, you'll have to bag the patient. and really the forearms get a workout.
Please explain what bagging is.
So normally when you intubate a patient, you connect the patient to a ventilator, and the ventilator helps breathe for the duration of the case. And the anesthesiologist can control how many breaths, so on and so forth. Here, there's no such machine. There is no ventilator. Once you intubate the patient, you then have to bag the patient throughout. If you don't bag, the patient doesn't get oxygen. So in addition to keeping track of everything else, you now have to be the ventilator as well, human ventilator. That's the patient intubated and ready for surgery. This is surgery itself. There's another interesting concept that we never thought we could learn from them, but they're brilliant in how they use their meager resources. This is one sterile table that serves both surgeries. You would wonder how that's possible. But what happens is there's a sterile nurse here, and she does not participate in the surgery at all. All her responsibility is in the sterile equipment. Whenever we need instruments, she passes instruments from here to either one of those cases that are going on. Once the instruments go to the table, they don't come back. You use them, and then they are all taken off the table and sterilized. These instruments, there's a sterile cover that goes onto them between cases, and they are used, and this sterility is maintained till the instrument is used. So there's no instrument that is sterilized without being used. This is more surgical pictures. This is the anesthesia. You can see that the anesthesiologist here is setting up for an anesthesia, for a general anesthesia. Well, the patient here is getting an epidural, both right next to each other. This is how the anesthesia machine gets packed back up, and it's standing on a plastic stool. Very, very innovative, very meager. One more anesthesia machine, again used in Desert Storm and being repurposed. More surgical. This is Brian Smith in action. He's getting ready to intubate a patient. Brian, we're used to such sophisticated equipment here. It took him a while to figure it out, and there was one machine that had a ventilator, and he would go an hour and a half ahead of time and guard it literally with this person so that he could have that machine every day. This is the only available fire extinguisher for the entire operating room. May I say that the entire hospital even, or it was just parked outside. This is the anesthesia supply room. This is after we unpacked everything. This is it's organized chaos, but our lean team could have done a real good job on this. This is the more immediate area where anesthesia medications were kept. Another shot of that. This is an example of how advanced those the cases that we did were. This is one uterine fibroid that measured more than 20 pounds that was being removed. And just to give you a scope of size, these are the hands, and this is to imagine that this poor lady carried this for God knows how many years without any chance of having this removed because she just couldn't afford the care. This is amazing. The hospital, we found this very interesting. Outside the hospital, the charges were clearly marked in laminated sheets, so there was no question, no doubt, no price gouging, no price elevations. Of course, this didn't apply to any of our patients, but we found that this was. I'm going to show a few examples of innovation. They did not have JP drains. A JP drain or Jackson Pratt drain is a closed drain system. Whenever we need to collect bodily fluids after an operation, we usually use those drains. And that drain has a little bit of a negative pressure so that it can suck out all of the fluids and prevent them from collecting in a space. So what they did was, we didn't have, and the first time I did a mastectomy, I said I need a drain. And they said, Doc, it'll be 20 pesos. So it basically translates into a couple of dollars. So I sent somebody to surgical supply store, and they brought me one JP drain. Then they ran out of JP drains. So the next day, when we had to do, said, Doc, we have a way of rigging a syringe and making it into a drain. So what they did was they took a 20 cc syringe, pulled the plunger back, drilled a hole in the plunger, and put a rod. And in order to protect that rod, they took two regular hypodermic needle caps and capped the ends. And so that's how they got the negative pressure, and this worked brilliantly as a JP drain. And so I learned a lot from them. This is one of our little patients, a concerned mother. So this is in the pre-op holding. There is very little comfort. There is no, you just take the little child away, and you can see the concern and anguish on everybody. Majority of the times, we didn't have separate beds for the kids, so we would put two to a bed, and the only identification was this piece of paper that we attached to them. There's absolutely no privacy. This is the only way we can identify all the patients in all of the chaos, that organized chaos. And none of the adult patients had a bed to lay down in the pre-op holding. They all had to just sit, and the kids were sharing beds. So you could see some of them in contemplation as to what's going to happen. Strange people, strange faces. Hopefully they'll be able to help us. This is the early morning huddle. The surgeons, along with the nurse, looking at our assignments. I don't think our board was ever that busy here. So we took our assignments and went on. This is Dr. Munchak manning the pre-op area. This is the post-anesthesia PACU, manned by our very capable ICU nurses, Chari, Apollo, and Athena. This is me making early morning rounds. I always had my camera with me because there were so many fascinating things to take pictures of. And if you notice, there are a few nurses and nursing students, but a majority of people sitting around are family members. And they provide about 80 to 85% of the nursing and care for the patient, whether it's personal hygiene, feeding. Other than passing out medications and changing dressings, the nurses did very little. Once again, you can see the family members and patients. This is a random shot of a unit. You can see the husband taking care of the wife taking care of the husband. There is no such thing as male wards, female wards. There's absolutely no privacy whatsoever. These are our volunteers. Actually, these are patients' family members walking around with their IV bags as they're going to the toilet. So everybody helps each other or their own. This is an example of how we actually helped out. This is not one of our patients, actually, but there was a code situation, and our ICU nurses jumped in and resuscitated this patient on the wards, and this is the same patient being transferred into the ICU. So not only we took care of our own mission patients, we jumped in and helped the local folks when help was needed. This is the nursing station, no Epic. But the good thing was we documented everything. The organization was to such an extent that we had notes, documentation of what we did, so that when we walked away from there was still a document of what was done to the patient that they could take and keep it with them. And that goes to show how well this particular mission was organized. They had their own personal stationery, the mission stationery, not the hospital stationery, because the hospital didn't want us to use their stationery or their supplies. These are the smiling faces, Chari, Apollo, and Athena. It's around 7 o'clock in the evening, and they're getting ready for the night shift. And we did it exactly like how we do it here, 24/7 nursing shifts, not just not from 8 to 5 and then disappear. No, there was a shift at night. And these guys pulled night shifts throughout the mission, and they always had these smiling faces. I don't know how they did it. This is the 2-bed intensive care unit. We didn't have any patients there, but I just wanted to show you the picture of the intensive care unit and the gases and the ventilators. Even in the ventilators, it's not standardized. This is the one good ventilator. This is a ventilator from the 60s. These two guys were critical in our mission. The two biomedical guys who always were fixing. They had their wrenches, they had their tool belts, and they're constantly fixing stuff for us in order for us to do what we did. Every day in the morning, they would be fixing, and in between cases, they would be fixing, just continuously fixing. I think very, very critical role. This is Dr. Breton and Dr. Manchak, the intensivists, our intensivists, and Dr. Breton is the Filipino Medical Association incoming president after Carmen. You'll be introduced to him in a few minutes. Is Dr. Halimi here? Dr. Halimi is working in the emergency room, and he said he would try and make it if he could. But Dr. Halimi manned the minor surgery unit, where they did more than 100 cases. Very little to go by. Patients many times we didn't have local anesthesia, and they did not complain. And a lot of these procedures, we would have done them under anesthesia in a surgery center or in the main hospital here. This is a small laceration that was being sewed up, but they were not simple cases. They were called minor cases, but they were not simple by any means. Very little help. One blood pressure medication, one blood pressure manometer for the entire floor. Everybody fought for that, but they managed to use it, and they managed to use it effectively. Everybody's vitals were taken. This is a ventilator education that our RT James Johnson was giving to the nursing students. More pictures of the staff, our nurses with their staff. All the folks in white are local staff members, and the one in blue are ours. More pictures of. One thing that you'll notice is you cannot stop smiles. Everybody, no matter how tired we were, you couldn't stop us from smiling. You couldn't stop, and the locals really, really appreciated the teaching and the education and anything that we did. Even if we didn't do anything, if we just smiled at them, they would smile all day long. And I don't know how they did it. This is my friend and one of our colleagues, Dr. Sandhu, giving a talk to the Filipino Medical Association. This is like a CME talk. Actually, this is the whole medical society, physicians. So we had a dinner talk, and Dr. Sandhu spoke about causes, treatment, and advances in hepatitis. This is Dr. Manjok. She gave a speech on sepsis, and then you'll see a bunch of different pictures of dentists and doctor volunteers and other staff members. You can see all of us from Washington Hospital out here. Dr. Breton, Dr. Akawali. These yellow T-shirts were the mission T-shirts, so people could recognize us. People could recognize us no matter what, whether we had the yellow T-shirts or not. These are the support group, everybody from Berkeley students to volunteers, our PACU nurses, Berkeley volunteer students. This is the entire Washington Hospital group, nurses, doctors, spouses, and this is the entire group. This is a plaque of appreciation given to Dr. Akawali by Governor of Bohol. I'll leave you with that. Thank you.
So it says here, it is not what we give, but what we share. for the gift without the giver is bare. In the end, we got more than what we gave. So these are all the doctors and nurses and support group involved. Can we ask you to stand up for us?
Please
Dr. Sandhu, Dr. Britton, Lydia Gapasin, and Lydia is a former ER nurse here that lives in Fremont. My husband Arnold, Ben Gapasin. We have Gina Arguelles, OB, Washington Hospital, and Ron Arguelles from Central Supply. So I'd like to hear from Dr. Goni Sandhu. Share your story, just maybe one story. So the 15, the doctors, Kranti Achanta, Goni Sandhu, Brian Smith, Kadir Halimi, Janice Manjuk, Dr. De La Cruz, and myself, they're all from Washington Hospital. Go ahead, Dr. Sandhu.
I don't have any slides. So it was just, I think the mission itself was my first, but it was eye-openers. I think the organization was amazing. From the airport to coming back, it was so organized, it blew me away. You know, my experience from all this reminded me why I went to medical school. When I wrote the letter of intent, so why do you want to go to medical school? I still have it. And that's what it really reminded me. Although we do so much here, right? There, the people I would walk in the morning, I see a mile-long line. They came the night before. And the symptom and the disease process they had was so far gone because they never got any preventive care. And for us, the only tool we have is pen and the prescription pad. Some of them you couldn't even afford it. I mean, if the medication was like $5, that's like 250 pesos to them. And sometimes they would come back and say, no. I said, why? It's 250. I said, okay, here's $5. Because that would have been helpful. I remember one lady, she tremendous amount of pain. You know, I did a consultation from station to station I would walk around, what they call. And I reviewed everything. She had recurrent pancreatitis, tremendous amount of pain. Would go there to send them home. She needed the gallbladder out. And all these surgeries were previously planned and approved by the governor. I said, you need to get this out. And I talked to Carmen. She said, no, it doesn't work that way. I said, yes, it will. I talked to Dr. Achanta. We organized it, walked her over, got her in there, got a cholecystectomy done. So the point is, you know, I think it gave me more than what I give. It reminded me why I became a doctor. So it was the most beautiful, wonderful experience. The people were phenomenal, and all we had was to go basic, just like he showed. Work with what you can. If you don't have a JP drain, use your syringe, and it works. Make it happen. So for me, it was the most beautiful, gorgeous experience I would ever have in my life. I never done the mission work before, but I am going to now. Thank you.
So our OB nurse, Gina Arguelles, come over, please. You're the only nurse here. But she has been joining the medical mission for a couple of years now. If they send her to, she's our OB nurse here at Washington. She's in charge of the minor surgery department. So just tell your story a little bit.
I work at the birthing center, and I've been going with the group since 1997. Since I started, I never stopped. It's like you feel like you're needed there. So it's even though you spend your vacation hours doing the mission, but it's worth it. And this time I had the chance to work with Dr. Halimi, our ear doctor. So we were together in minor surgery doing that. So it was fun.
And I just saw Kim Sullivan, our ICU nurse. Kim, you want to tell your story? They had a lot of magnet moments, I'd say. The ICU nurses from Washington Hospital did not say no when they were given 3 nights of duty. They're supposed to have only 1 or 2 every night, but they said yes because we didn't want to embarrass you, Dr. Agawili. We just want to be good, so everything goes well with Washington. Want to tell your story?
Yeah, I started out, the first night I worked night shift. It's very interesting, it's very different doing medicine in third world country. But the nurses there, at their own nurses were really great, and they do so well with so little. It's amazing what they can do. Our experiences were great though. We had great outcomes with our patients. They all were able to go home by the end of the week. There was one patient that stayed a little bit longer because she had had more major surgery. And all the patients are just so appreciative. It's so fulfilling to go and do this.
Thank you. And last but not least, I want to introduce our incoming president, Dr. Peter Britton, and our energetic mission coordinator, Dr. Araceli de Guzman. Dr. Britton is a transplant surgeon from UCSF and from Marine, and Dr. Araceli de Guzman is an anesthesiologist from Alameda.
Thank you, Carmen, and thank you, everyone here. You have seen that this is a life-saving mission, and you have been very supportive, and we are all very grateful of your support from this hospital. I hope that you feel that you've contributed significantly to lives saved. The Philippine Medical Society has been doing this for 30 years, often without any help and raising it on their own. And I just want to share with you a really brief story on how important that simple acts of kindness can reverberate, and they can recur, and they have a long-lasting effect. There was a skinny Filipino man, he was dying, and basically was considered a non-surgical candidate. And one of the surgeons came by and just saw the 8-year-old son with him, and the patient was getting the last rites. And the mother said, well, tell his son, my son, that he's going to be the man of the house because father's going to die. The surgeon decided he'd give it one last chance and took the patient to the operating room, and somehow doing a new procedure, the man survived. Well, the experience was so intense with the little boy and so profound that about 25 years later, he became a transplant surgeon to save lives, and that was me. And it was long-lasting. I just heard Dr. Sandhu say, why did we go to medical school? I think it crunches down to just saving lives. And that's what the mission comes down to the core. It's all about saving lives for just a simple act of kindness. So I thank you from the bottom of my heart, having seen and being on the receiving side of things, that being on the other side is easier, but I can never repay that one surgeon here in California, where I was born, for saving my father's life. That is the core of medicine. I think that's why we went into medicine. So God bless you all, and thank you for supporting Carmen here. Thank you.
Thank you, everyone. Thank you, Ms. Nancy Farber, and we would like to thank as well the Board of Directors for such tremendous support. And I would like to ask Dr. Agkawili now here to give a little appreciation on behalf of Washington Hospital. We would like to call on Ms. Farber to receive a little recognition letter. Please come.
It's a certificate of appreciation to Nancy Farber for a generous donation and support on behalf of Washington Hospital and the Board of Directors. Thank you very much, Nancy, for supporting the mission.
Thank you.
Okay, thank you.
Thank you so much.
I'd like to just say a few words. This is a project our hospital supported through donation of surplus supplies. It's also something I personally supported because I feel so strongly about Carmen Aguilli as a leader, and everything she's ever told me has been spot on, and that she led this effort made me look at it with a lot more attention. Clearly, they've shown tonight that when donations have been made, either in surplus supplies or in dollars, that they have gone where we were told they would go, and all of them were used to the benefit of the people that they were going to be serving. So when this event comes up next year, I hope all of you will recognize it as a very worthy charitable activity and think carefully and reach into your pocket and help them do this again. This is an area that has been devastated and by many parts of the world forgotten, but it's not forgotten here. And our Filipino community and the hospitals that they work in should share in the effort to help these people. They're certainly deserving, and our doctors have done an amazing job. Our nurses, I couldn't be more proud of our medical community. And I want to thank you on behalf of the organization. You've done us proud. Thank you very much. We would like pictures, yes. Could we get all of the doctors and the nurses together? With our board of directors, please. I want to get a picture of it. It is amazing what they did. CEO. Let me CEO. Not be complete without a CEO. Arnold, you have to join us.
Thank you.
I love you, Carmen. You are the best. Thank you so much. It was a gift that you gave. Absolutely. It's insurmountable love. Thank you.
Thank you, Nancy, for arranging that.
I'd like the board to consider for their next open session, offering commendations to all the members of the medical staff and our nursing staff who have participated in this mission. And should you agree, I'll prepare them for you.
I think that's a good idea. Rest of the board?
I think what they've done is extraordinary.
What I heard was a lot of them saying thank you to us, but I think the thank you needs to come from us
To them.
To them. I have no words. There's just no words to say what they've done. It's very humbling
It is.
to see what people are doing with next to nothing to take care of people that are so much in need.
And Goni Sandhu's remarks, I think, were particularly instructive in the sense that it reminded him of why he went to medical school. And I'd be willing to bet that the nurses would say the same thing about their choice of nursing as a calling. And I think this is medicine at its finest, and I'm so proud to be associated with these people.
Thank you. Thank you. All right, moving on our agenda. We have consideration of the minutes of March 11th and the 23rd of 2015. May I have a motion to approve?
So moved.
Do we have a second?
Second.
Thank you. Any discussion about the minutes? Okay. All in favor?
Aye.
No, wait a minute.
Nope, can't do it that way.
Christine, would you please take the roll call?
Director Danielson,
Aye.
Director Wallace,
Aye.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Epen.
Aye.
Are there any oral communications? Seeing none, we'll move on to written communications from Dr. Peter Lunny.
Thank you. I have the March credentialing action items from the medical staff. We had 4 new applicants. Dr. Ray Pai Chung, OBGYN, Dr. Rajni Sethi, Radiation Oncology, and Dr. Brenda Shu, Radiation Oncology, and Anja Strelo, Physician Assistant in Surgery. Temporary privileges were granted to Drs. Sethi and Shu and to the PA, Anja Strelo. We had one withdrawal of application from Dr. Diana Carcamo Molina. For the following individuals were recommended for 2-year reappointments: Dr. Ibrahim Ahmadi, Family Medicine; Dr. Muni Barish, Internal Medicine; Dr. Patrick Duffy, Oral and Maxillofacial Surgery; Dr. Victor Maceda, Family Medicine; Dr. Neeta Patel, OBGYN; Dr. Robert Pipkin, Cardiothoracic Surgery, Administrative; Dr. Aruna Reddy, Family Medicine, Ambulatory Status; Dr. Sharon Singh, Neurology; Dr. Meena Tandon, Pathology; Dr. Dale Tyler, Otolaryngology; Joelle Whalen, PA in Surgery; Dr. Joseph Zamudo, Family Medicine; and Dr. Milford Zaslow, Anesthesiology. We recommended a 6-month reappointment for Dr. Rajesh Suri, a conditional 6-month reappointment due to aberrations in the use of our medical record. Non-reappointments deemed to have resigned: Dr. Hassan Bey from Neuroradiology. Completion of proctorship in advancement in staff category: Dr. Amy Harold, OBGYN, and Dr. Owanza Puplampu, OBGYN as well. We had 3 medical staff members who completed proctoring prior to advancement in staff category. Those would be Dr. Eric Chen, Teleradiology; Dr. Holly McCune, Teleradiology; and Elizabeth Lewis, Nurse Midwife. A new privilege request from Dr. Diana Lowe, OBGYN, for newborn circumcision. And we have 3 resignations: Dr. Igor Bedorov, Igor Bedorov, RN First Assist; Dr. Singming Liu, Pediatric Hospitalist; and Dr. Shali Sinha, Pediatrician.
Madam President, I move
Yes.
for approval of the credentialing action items as presented.
Thank you. Christine, would you take a roll call for approval?
Director Danielson,
Aye.
Director Wallace,
Aye.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Epen.
Aye.
Motion passes. Thank you. We now have the Service League. So Debbie, would you give us an update?
I'd be happy to. In March, we had our first meeting as president. I had my first meeting as president with the board, and everything went really well. I'm very encouraged at what the how we're going to be moving. We just had another board meeting today, and everybody is looking really good, and I'm very proud of the new board. Some of the things that we have been accomplishing so far is we have our disaster list in place. In the event of a disaster, then we have the right volunteers that are going to be out there to get to the hospital to aid the hospital in whatever may need be done, okay? Also, we are in the process of redoing our brochure right now. And the brochure is close, but not quite there. We're working with Ruth, and hopefully within the next month or two, we'll have that completed. We wanted to have a brochure that was more generic, that it wasn't, it would go for a long period of time. So it wasn't like the board on this particular board brochure, so that we would have to change it every year. So we're going more generic. The Service League also donated $1,000 to WOW, Washington on Wheels, to help with the costs that they go through. And I think that very proud of that we were able to do that for them. And now we're in the process of scholarships. We have received 9 candidates for scholarship. We have the staff representation from the hospital will be Vida Reed and Angus Cochran will be doing. I think they'll be an excellent addition to that team. Of our first and second vice president of Jose Aguirre, as well as Pooja Mahan. Okay, Diane Zarzinski is our chairperson, and she's working very hard at getting this all pulled together, and we will be starting our interviews on May the 11th in the evening. Right now we have 2 4-year scholarships, $1,000 a year, but all our scholarship recipients must be going into the medical field. We also have a 1-year scholarship of $1,000 in the name of Anna Iola, and another scholarship will be awarded this year, a one-time only, in honor of Jerry Claridge, who was our first Director of Volunteer Services. So unfortunately, she passed away in February, and we have had memorials come in, donations in her name, so we will be doing a scholarship in her name this year as well. Inventory for the gift shop has been completed, and our masquerade jewelry sale is coming up. I know Nancy's excited. She's got her flyer, and we hope that everyone will come out for that and support it as well. We are going to be putting flyers out amongst the community, and it will be on the website as well. And so please, this is a big fundraiser for us, as well as our gift shop for our hospital. So, and plus you get really great buys. Everything's $5.
Debbie, can you give us the dates?
I'd be happy to. It's going to be May 4, 5, and 6.
And
Okay.
that's right before Mother's Day, isn't it?
That's right before Mother's Day. And it's going to be on Monday and Tuesday. It will be from 7 in the morning until 6 in the evening. And then on Wednesday, it will be 7 in the morning until 5 in the evening. So.
And the location?
Location is right here in the auditorium, the Anderson Auditorium. We're going to have 2 auditoriums this time. So we'll have more space and lots more merchandise, hopefully. So.
Right, because last time you did it, you had, was the last day that you branched out into
Yes,
two
yes,
two
yes.
spaces? So that means more stuff.
Right, more stuff, and it gives people the opportunity to really go through their stuff. I love watching them get in their little corners, and they're all going through their baskets, and okay, I got this and this, and it's great. It's great fun. It's a great fundraiser, and everybody really looks forward to it. So
Was that FUN raiser or FUND?
both.
What I found is that you have to come every day.
That's right. You do, because we bring out new merchandise. Casey, they bring out new merchandise each day, so as you ladies know. Our
We
big
well know.
supporters. So thank you.
Okay. Great, thank you very, very much,
You're
Debbie.
welcome.
Good report. Dr. Lunny, we're back to you with a medical staff report.
Thank you. First, I'd like to say that volunteerism personally plays a very large role in my life. So I was immensely proud to see our medical staff members participating in that volunteer effort in the Philippines in January. They were missed when they were gone here, but to see the work that they were doing there is just incredible. So the current status of our medical staff, we have 545 members, 338 of which are active, 92 provisional, 63 ambulatory, 26 courtesy, 17 allied health, and 3 with temporary privileges, as I was stating with the credentials items. And then we're currently embarking in some education to update us with regards to changes in the EPIC electronic medical record.
Very good. Thank you. Nancy, would you please give us the hospital calendar?
Start with the video, Joe, please.
Past health promotions and outreach events. During the month of March, Lucy Hernandez, Community Outreach Coordinator, presented 4 hand hygiene classes for students at Wybell Elementary School in Fremont. Information was provided on proper hand washing and hygiene to prevent infection and the spread of germs. 108 students participated. On Tuesday, March 17th, Dr. Michael Parmley, internist, presented Healthy at All Ages. 16 people attended. On March 21st, Washington Hospital hosted Stroke Awareness Day. This free event screened community members for carotid artery blockage, atrial fibrillation, as well as cholesterol, blood sugar, and blood pressure screenings. The event was staffed by Dr. Ash Jain, cardiologist, who provided results interpretation along with Washington Hospital personnel. Volunteers from San Jose State School of Nursing and the Washington Hospital Service League also assisted to make this event a success. There were 70 community members screened. Of those 70, 13 were found to have mild blockages, 3 were found to have atrial fibrillation, and 25 others were found to be at high risk for stroke based on other risk factors. On Thursday, April 2nd, as part of the Diabetes Matters series, Bing Bing Zhang, RN, presented gastroparesis, when diabetes leads to a lazy stomach. 15 people attended. On Tuesday, April 7th, as part of the Stroke Education series, Dr. Ash Jain, cardiologist, Doug Van Houten, RN, and Luann Sodweste, RN, presented Acute Management of Stroke, Chronic Care and Stroke Rehabilitation. 20 people attended. Upcoming health promotions and community outreach events. On Friday, April 17th, Kitayama Elementary School in Union City will hold a health fair for students, teachers, and parents. Washington Hospital nurses and staff from respiratory care will provide information on asthma, hand hygiene, and offer blood pressure screenings. On Saturday, April 18th, from 10 a.m. to 2 p.m., Washington Hospital will host the 9th Annual Women's Health Conference. This event will feature topics such as prevention and treatment for gynecologic cancer, healthy joints, and nutritious meals on the go. Dr. William Degoni, Medical Director for the Washington Women's Center, will provide an update on the Washington Women's Center, and Dr. Victoria Liebhart, gynecologist, will moderate the event. On Tuesday, April 21st, from 1 to 3 p.m., Dr. Bruce Lynn, radiologist, will be presenting Relieving Chronic Pain, Know Your Options. On Saturday, April 25th, from 11 a.m. to 2 p.m., Washington Hospital's Green Team, the City of Fremont, and other local Tri-City organizations will present the Let's Go Green Together event. This free Earth Day Education Expo will raise environmental awareness and share eco-friendly ideas with people in our district. Attendees are encouraged to learn about recycling and how to save energy. On Monday, April 27th, from 7 to 8:30 p.m., Dr. Victoria Liebhart, gynecologist, will be presenting Restoring Balance, a 4-week stress reduction program. On Tuesday, April 28th, from 6 to 8 p.m., Michelle Heading, RN, Spiritual Care Coordinator, will be presenting Future Planning and Advanced Healthcare Directives. On Friday, May 1st, from 3 to 5 p.m., Dr. John Dearborn, orthopedic surgeon, and Dr. Alexander Saw, orthopedic surgeon, will be presenting treatments for knee pain. On Tuesday, May 5th, from 6 to 8 p.m., as part of the Stroke Education series, Dr. Ash Jain, cardiologist, Doug Van Houten, RN, and Luann Sodweste, RN, will be presenting Stroke Prevention and Other Disease Processes, Healthy Lifestyle, Be smart and avoid stroke. On Thursday, May 7th, from 7 to 8 p.m., as part of the Diabetes Matters series, Dr. Khalib Beg, Family Medicine, will be presenting What Do All Those Labs Mean? Understanding and Using Your Results to Improve Diabetes Management. The Washington Hospital Healthcare Foundation Report. The Washington Hospital Healthcare Foundation's 30th annual golf tournament takes place in just a couple of weeks, on April 27th. In memory of longtime Fremont businessman Jean Angelo Pisano, the tournament promises a day of great golf and fun surprises. Tournament chair Lamar Hinton promises another enjoyable tournament. He says, "We had a great round of golf at Castlewood last year, so gather up some friends and enter a foursome. It's a great day out and it's for a great cause." To reserve your foursome, please call Washington Hospital Healthcare Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members attended the Indo-American Community Federation's Unity Dinner on March 20th. At the Unity Dinner, board members Patricia Danielson and Dr. Jacob Epen were presented with the Indo-American Community Federation's Leadership Award for their service to the community. Board members also attended the Alameda County Special Districts Association's annual dinner on March 26th and the Fremont Chamber of Commerce's State of the City address given by Mayor Bill Harrison on March 27th. Washington Hospital Employee Association, WIA. On Friday, March 13th, the Washington Hospital Employees Association, in collaboration with the American Red Cross, hosted a blood drive. There were 21 donors and 19 units of blood were collected. The Washington Hospital Employees Association is currently accepting scholarship applications for the 2015 Don Pickenpaugh Memorial Scholarship. Don Pickenpaugh was the longest-serving board member on the Washington Township Healthcare District Board of Directors. During his 27-year tenure, he served as board president 5 times. This $2,000 scholarship is available for dependents of Washington Hospital employees. For more information, please contact Christy Caracappa at 510-494-7005. Washington on Wheels, WOW, Mobile Health Clinic. During the month of March, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Family Resource Center, the Fremont Senior Center, and Briar Elementary School in Fremont. The total number of community members receiving health care at the Washington on Wheels Clinic during the month of March was 46. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was March's most viewed webpage with 15,237 views. InHealth, Channel 78. During the month of March, Washington Hospital's cable channel 78 InHealth captured new programming, including a Diabetes Matters program, Diabetes and Your Skin, a health and wellness program titled Healthy at All Ages, and the Washington Hospital Experience, the Birthing Center. In addition, InHealth aired Severe Sepsis, Don't Let Infection Take Over Your Body, a Diabetes Matters program titled Healthy or Hoax. The March Board of Directors meeting, 2 heart disease public service announcements titled The Breakup and the Resignation, and a stroke awareness public service announcement, Body Language. Additional events. On Saturday, March 21st, the Washington Women's Center was recognized during Alameda County's 22nd Annual Women's Hall of Fame for its support in the community. Through this event and other community activities, the Women's Hall of Fame generates funds to support organizations that help women and families in Alameda County. The Washington Women's Center was selected for its efforts to provide comprehensive breast cancer prevention, education, and treatment services. The Washington Women's Center received a $2,500 contribution in support of the services provided. Washington Hospital celebrated National Doctors Day on Friday, March 27th, by hosting a luncheon for members of the Washington Hospital medical staff in the Anderson Auditorium. The event was the organization's way to recognize physicians for their service and commitment to their patients' health and well-being. Approximately 120 physicians attended the event. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070. And please follow us on Facebook and Twitter.
Takes a minute for your eyes to adjust after that. My next business is to introduce our Employee of the Month. And this is Tricia Ploskaru. She's a central registration clerk in our central registration department, which is part of the finance division. She's our April Employee of the Month, and she's a very deserving recipient. She has an enormous commitment to patients, and her daily execution of the patient-first ethic is remarkable. I'd like to say she comes by this honestly. Her mother is Maria Ploskaru, charge nurse on 6 West, another mother-daughter combo at our hospital. And with her mother's incredible example, I don't have any way of thinking that her daughter would be different. Tricia is extraordinary, and we're delighted to have both of them in our organization. She's been with Washington Hospital for 15 years, another committed Washington Hospital employee. She's worked in various departments in the healthcare system as a registration clerk. Over the last 4 years, she's worked as a central registration clerk in the Women's Center and Medical Imaging Department, and she also can be found supporting our outpatient lab. She provides support to our Washington Wellness Program, which is housed in the Women's Center. She's very pleasant. She has a comforting style. She's noticed by patients, and often this is communicated to her supervisors. In her spare time, she spends time with her family and outdoors. She loves to explore new hiking trails or rock climbing sites. She's also an international volunteer, and she has been part of numerous international volunteer groups that support missions in different parts of the world. That seems to be a theme tonight. So I'm very pleased to present Tricia. Thank you.
I see that we have our construction update with Ed Fayan.
Thank you, Pat. So we'll start with the parking garage. We've had a fair amount of activity out on the sites this past month. So began with the pad excavation. The excavation of the garage isn't as big of a dig, I guess, as what we'll see with the Hyman Pavilion, but still it's dropping down a couple of feet. And we've had this going on actually over the last several weeks. So we have a large number of trucks coming off site, and there is a constant off haul of debris from the grounds, and it's very busy in the back of the campus now. This is the beginning of excavations for the grade beams. As you know, all the pylons have been drilled, and this is the grade beams that are going on top of them. So that's actually, even the digging is even more pronounced now if you were to go out there. Most of the grade beams have been laid out. This is still our path forward. The only thing that's different in this one is we're still planning to be done by February of 2016. However, this is showing the contract dates because there's days in there for rain delays, other delays that are provided, sort of no-fault delays for the contractor and for us. So this is the extent of the contract. We haven't changed the completion date. Okay, in the Morris Hyman Critical Care Pavilion, we had steel delivery on March 18th, and this is the beginning of the shoring. This is the drilling that's going in place, so that steel is dropped into place so we can get the retaining walls put in place. And again, this is the beginning of the big dig here. So if you were to go out on the site now, it's down about 10 feet for about 3/4 of the of the area that's going to be dug out. If you walk that site, there's actually a change in elevation. So if you're back by the loading dock, you don't notice it as much because you're basically at 10 feet down, you're sort of at grade down there. So in the building, that will actually be the basement. Whereas in the front, where you get close to the Civic Center, you won't be able to see the basement. So this dig is going on, and we're going to be going down 40 feet. So that'll be going on for a while. Here's our time frame still for the bids. As you might recall, 80% of the project is bid. It's the last 20% that's going to be completed this month, and we'll have numbers in May. Any questions? Thank you.
Thank you, Ed. Next on our agenda is our quality reports with Mary Browen, who is the Senior Director of Quality and Resource Management.
Good evening, thank you. Tonight I wanted to talk a little bit about our infection prevention program. We like to provide an annual update so everybody can understand the program and what's involved and how comprehensive it's become over the last 10 years. There's really been a focus on improving infection prevention efforts in hospitals. And as a result, a lot of what we do has even become regulated because now it is the government and groups like CDC and everything have recognized that a third of the cases of hospital-associated infections are preventable. And hospital-associated infections are among the top 10 leading causes of death in the U.S. today. But you can reduce these infections if you have close monitoring, there's lots of education in the hospital, and you use evidence-based practice. The good news is there's a lot to show that we can prevent hospital-associated infections and bring down those rates. So here at Washington Hospital, we have an infection prevention committee that was established in 2006 as a response to the increased focus on how we can prevent hospital-associated infections, otherwise known as HAIs. And the primary focus is really how do we eliminate these and keeping in touch with what's the evidence-based practice that the committee can come together and look at and come up with goals and strategies to get these HAIs reduced. Currently, the members on our team are Dr. Martin. She's our infectious disease consultant. She's been chairing the committee. I also sit on the committee, and we work with the infection preventionists and all other disciplines in the hospital, even environmental services, nutrition, laboratory, pharmacy. Everybody comes together once a month and sort of re-collaborates on what's the plan for what we can do to reduce HAIs. Really the goal is improving overall care for patients, improving the quality, making sure that it's patient safety driven, and that we're following evidence-based policies and procedures and remaining current with those, and that we're really doing active surveillance, that we're looking in the hospital for who these patients are, if we're at high risk for developing these infections, and when they do happen, going back and performing a root cause analysis so that we can understand maybe what led to an event such as an HAI. We also try to stay on top of outbreak management and antimicrobial stewardship, which is really a group of pharmacists and another interdisciplinary group in the hospital that meets monthly, really looks at, are we being cautious and using antibiotics appropriately? Once a year, we sit down with the ID consultant and with the infection control committee, and we do a risk assessment. And in that, we look at the past events, the past HAIs that we've had, and try to figure out what was our biggest problem throughout the year, what are some things we did that worked, and where do we want to put our resources in the next year. So that's done on an annual basis, and from there we develop our infection prevention plan for the year, and that's done every year. Here's just a list of the dictionary of infections, and the point of this is just really to show that there's some good, concrete, standardized definitions that you can use to follow to determine if somebody has had a hospital-associated infection. And a lot of them are listed, the multiple drug-resistant organisms that are hard to treat, and things where patients can develop infections if they have medical devices, that sort of thing. So we do follow strict definitions. The other piece is we report this data out. That's one of the biggest changes in infection control, especially in the last 5 to 7 years, is this, the government is asking for this information. They want to know how many hospital-associated infections do you have? And so we report them to National Healthcare Safety Network, otherwise known as NHSN. This is a large database that works closely with the Centers for Disease Control, and we report all hospital-associated infections to them. This is reported monthly, and then they're able to give us back data letting us know where we sit compared to other hospitals in the United States. Another group is, of course, the Centers for Medicare and Medicaid Services, otherwise known as CMS. We report mandated data to them. This is going to be things like all patients that have a colon surgery, all hysterectomies, patients that have central line infections or a catheter, a urinary catheter infection. All of that gets reported to them, and they review that data. California Department of Public Health is another group that we work closely with, reporting any, this is typically more of a focus on community outbreaks, that sort of thing. And also same with Alameda County Public Health Department. Work really close with them on communicable diseases such as TB. So our surveillance program really is about what are we watching closely for? What do we monitor every day that we think may be a risk factor in the hospital? One of them is during influenza season. We strive really to make sure that the employees are protected against influenza and therefore are not a risk to exposing our patients to influenza. You can see that this compliance rate for basically employees getting their flu shots has increased drastically, especially since 2012. That's because the Alameda County mandated that we have our staff get influenza vaccinations or sign a declination as to why they cannot. So the last year we had 93%, and for influenza vaccination, that's if you compare it to the rest of the nation, that's a really high compliance rate. We also want to offer patients while they're here visiting an influenza vaccination. So every single patient during influenza season is asked by their nurse and screened for if they've had their influenza vaccine. If they haven't, we like to get that for them before discharge. And January through March of this year, we reached above the benchmark and had 97% compliance rate on getting patients who wanted to be vaccinated prior to discharge. Those vaccines are especially important when you look at data on this slide. If you look at January, February, and March, that tells you just in the ED how many patients came in with what we call influenza-like illness. We haven't determined at that point for sure if they have influenza, but they came in with the temperature, the cough, the respiratory symptoms. January was a really busy month for us, so 22% of the people who walked in the ED that month had influenza-like illness, and same with 21% and then 18% in March. So just another reason for us to concentrate on using preventative efforts through vaccines. Another area that we survey closely are patients that do have medical devices implanted on them during their stay with us, patients who can't breathe on their own and need a ventilator, and that's a risk factor for developing pneumonia. And you can see that luckily the last 2 quarters ending last year, 9 and 12-14, we did not have a patient develop any signs of pneumonia while they had their ventilators in place. There's a lot of things that the critical care staff does and works very closely to make sure that we can reduce the risk of a patient developing what's known as a VAE, ventilator-associated event. The other one, catheter-associated urinary tract infections that I mentioned earlier. Same thing, we've had a good outcome with that. Anything below the blue bar basically means that we are doing better than the rest of the nation with making sure that patients who have to have a urinary catheter do not develop a catheter-associated urinary tract infection while they're here. This comes from the NHSN database that I mentioned earlier. Another device-related one, central line-associated bloodstream infections. This has really, we've really made some efforts in critical care to reduce the risk of this happening. And when we do have a patient who does develop a central line associated bloodstream infection, we take it seriously. We meet with the Dr. Akawili, who was just up here earlier. She meets with our ID consultant. We meet with the nursing staff, and everybody really looks down and says, how did this event happen? What can we do to prevent it from happening again? And I think those efforts have really paid off in the last 2 quarters of last year. We did not have any collapse in the critical care. They have implemented things like chlorhexidine baths that they give patients every single day that reduces the infection of them getting a central line infection, because it really reduces the microbes on their body that could be at risk for getting near the central line. Another area is patients who come in to have surgery obviously are at risk for developing a surgical site infection. We monitor every one of these patients for up to 90 days after to make sure that they haven't had an infection, and we follow them closely. And we have actually some software that helps us to know even if they had a lab that came back positive from a wound, it will come to infection control and we can review it. So I feel like there's really good surveillance with this. And we've done well last quarter, 12-14. We were under the benchmark for patients, only 0.4%. Vancomycin-resistant enterococci, otherwise known as VRE, another infection that's very difficult to treat with antibiotics. What the CDC requires is that if we have a patient who gets this while they're in the hospital, we have to report that to them. And last 2 quarters, we did not have any VRE in the blood. And I'll talk a little bit later about, I think, some of the efforts that have really reduced the incidence of any multi-drug resistant organism coming into the patients here. And that is this, the Hand Hygiene Compliance Initiative. So we've talked about it here before, that in April of 2014, we implemented the Joint Commission Targeted Solutions tool. This is a standardized tool that really helps you get your hand hygiene compliance rate up. And there's a lot of evidence that says that that is still the best thing you can do to prevent hospital-associated infections. Hand hygiene, washing your hands. So we've had an average increase of about 35% compliance with hand hygiene. And what's interesting to note is you can see right there where the balloon line comes down where we started doing this. Since we've implemented this program, we have not had a single case of MRSA, which is MRSA, a difficult bug to treat also with antibiotics. So we have not had that. It's interesting. It's not a correlation, but it's an associative relationship that we can look at and say, okay, so when we did this, we reduced the risk of that, it appears. Another thing that we've been able to reduce through using the initiative of hand hygiene and improving our cleaning efforts here and our products that we use to clean, we've continued to see a decline in our C. diff. On the last quarter of 12-14, we were at 1.15, meaning that we had about what was expected compared to other hospitals that are similar to us. However, what's important to note is that it's been such a sharp decline in the last year. Today, we have half the hospital-associated C. diff infections than we had this time last year, which I think really relates back to some of the initiatives that I spoke about earlier with the hand hygiene and cleaning efforts. Another thing is that we do in the program is we want to watch and make sure that our employees are protected here. And one of the areas that we survey is employees that get needle sticks when they're doing procedures. This is a really high-risk group. If you're a nurse and you're constantly giving injections and dealing with needles, it could be at risk for a needle stick injury. So for our fiscal year 2014, we did have roughly about 26 staff that did get poked by a needle. There is not a standard benchmark out there for this, so it's hard to compare. I've worked with employee health a lot closely. It says that we tend to have a lower incidence than most other hospitals. But it's things like accidentally cutting themselves or sticking themselves or the needle being in the wrong place. So the key with this is that all this data goes to Workers' Safety Committee, and we drill down and look at each one of these and do a root cause analysis to see what we could do to prevent that from happening again. So that's closely monitored by the committee. We also have some laws in California that you won't find through the rest of the United States, but in California, it goes back in 2006. There's a Senate bill that came about that stated we have to screen certain groups of patients for MRSA. We screen every single patient who goes into critical care, every single patient coming in who's going to need dialysis, anybody who we're going to transfer to a skilled nursing facility, or anybody who's spent the night in another hospital within the last 30 days. And these patients tend to be at a higher risk for developing MRSA infections, especially while they're in the hospital. Same with the surgical procedures. all cardiac surgery procedures and back surgeries such as laminectomy. We screen all these patients within the first 24 hours. And the goal is that if these patients come in and they have MRSA, you want to isolate them, you want to make sure they're treated appropriately so that it doesn't spread in the facility. And we've had good compliance with that, especially in the last months of the end of 2014. We just about reached 100% compliance for that. Again, that's a state law. We have to watch that very closely to make sure we're being compliant. Another area that infection control works with are any type of new construction or renovation you have. It doesn't seem like infection control would have to be involved with this, but they are, because with the goal with infection control performing a risk assessment prior to any construction being done is that we can reduce the exposure of what chemicals and what may be coming out of the air during construction. We want to reduce that risk and make sure that patients aren't being exposed and that the employees are not being exposed to anything that could be harmful to themselves. So infection control meets with the construction team prior to any construction, and we go over and make sure that, identify, is this a low risk or a medium risk or a high risk or project that's going to happen. And by doing that, we can in place safety measures to make sure that people aren't exposed, such as patients and employees. With all the construction coming up, we'll be working closely with that team. Another big part of infection control is performing education. So important to make sure that the patients and the staff are educated on what we can do to prevent the spread of infection in the hospital. So we provide all patients with MRSA education. We make sure that they get that right before discharge. If it's a new diagnosis, the physician is required to go in and speak directly with the patient about this. We give them written documentation for that in addition to the verbal documentation. So we can also educate them specifically on any infection that we've identified while they're here. We have done some community outreach programs. Those have been basically led by Dr. Martin, our ID consultant. She's done some InHealth public service announcements, these sort of things, just to make sure the community is educated. And we also take the opportunity while visitors are here to talk to them about hand hygiene and preventing the spread of things such as the flu is one of our big focuses with visitors. Staff has to be educated. Every year, 100% of the staff have to take an infection prevention module. Even if you work in finance, you have to take an infection prevention module, to learn things about the importance of hand hygiene or what's going on to prevent the spread of illness in the hospital. We also have a website that's accessible to all staff at all times to look and see what our policies and procedures are. And we really focus on sort of what's the hot topic of the year? What are some things that we think may be a risk factor for coming into the hospital? What are some things that the staff need to know about in case it arrives in the ED? This year it was CRE, which is also another multi-drug resistant organism, very difficult to treat. Influenza is always going to be a focus for us every flu season. Enterovirus, same thing, respiratory illness that was really heightened in the last winter that we've been focusing on. And measles, which I'll talk more about in a minute. And then, of course, Ebola, which So all those things we gave a lot of extra resource to preventing the spread of. And we'll always be educating about hand hygiene. So with Ebola, I think everybody is very aware of the outbreak that happened in 2014. And really what we did here was immediately got together a team. It's an interdisciplinary team. Everybody from every area of the hospital was represented. And the question was, how are we going to handle this? If we have a suspect Ebola patient who arrives in our ED, what are we going to do? This task force met every single week. We had 1 to 2 hour meetings. We wrote policy. Nursing came together with physicians and pharmacists and EVS, environmental services. All these people came together to talk about what we would do. We also participated in a county drill, which I think we learned a lot from. It was, they had an actual suspect, it was an actor, but a suspect patient who arrived in the ED. So we got to go through and see, do our policies work? Is everybody educated? We were able to learn some things from that. We also required 100% of the staff to complete mandatory Ebola training, and our nursing staff was given training on how to put on your personal protective equipment and how to take it off. And we required that of 100% of the staff. We got in a core group that we figured needed to be able to be trained well when an Ebola patient came in. and really got that group set. But then we also trained other nurses who, may have to take care of a patient at any time. So there were a lot of efforts put into this. We did not end up with any suspect cases, luckily, so, but we learned a lot about how to respond to any unknown illness. Community health is also a big focus of the program. I mentioned earlier measles, and this was more in January where there was an outbreak. It originated in Southern California. This is a highly contagious infectious disease. We want to make sure that we identify these patients in the ER, get them masked, get them in the right room, and get them the right treatment that they need quickly. So again, where there was a lot of education from nursing and infection prevention on how to really work with, especially the ED staff, on what this patient would need if they were to arrive. And in fact, we did have 3 suspect measles cases arrive to the ED. None of these ended up being confirmed, but you just cast a wide net on who could possibly have measles. So if you had a fever and you had a rash, we looked into, wanting to make sure that, we did the best we could to prevent anything in case it was measles. Tuberculosis, otherwise known as TB, is another really big focus of our program, because in their area of Alameda County, you could see there's a much wider, higher incidence of TB throughout really the whole county. And any of these patients can come to this hospital. And in the other slide to the right, you can see that Alameda County has a higher rate of TB than even other areas of California and the U.S. So again, has to be a big priority here. We've really got to be watching and making sure that we catch any suspect or patient coming into the ED who has TB. Very highly contagious, but it's preventable if we put in the right efforts when they arrive here. So the other thing we do is we screen 100% of our staff to make sure, this is done on an annual basis, to make sure that they themselves don't have TB, so we're not putting anybody else at risk. And we work really closely with infectious disease medical consultants, the lab, infection prevention. Everybody comes together when we have what we call a suspect or a confirmed TB patient, and comes together and really reviews and rounds on this patient every single day to make sure, are they getting the right meds they need? Does the county know that they're here? All that, all those efforts are made to make sure that we keep this patient isolated and provide them the same quality of care that they need while they're here. Pertussis whooping cough is another issue that has come up in the last year. We did not have any pertussis show up here. We made some efforts to change and update our policy to make sure that we were prepared, but nobody actually arrived as a suspect pertussis patient. But we were able to take that opportunity and make sure that all of our staff was vaccinated. So employee health worked closely to make sure that they did audits on our employees to make sure and have them come in, and they drew blood to make sure that these employees were vaccinated against pertussis. So we were prepared, but it didn't end up coming through for us here. Some future directions of the program are focused on really just making sure that we're compliant with all the evidence out there. The evidence is changing every day. We want to make sure that we're aware of what's going on, what other hospitals in the area, what CDC is recommending to reduce hospital-associated infections, and continue to round and work with all the disciplines in the hospital, and to make sure that we're limiting any risk of transmission. And we really want to just sustain the initiatives such as what we mentioned before, especially with hand hygiene and our C. diff initiative. That's it for the program. Thank you.
I find it quite interesting that when we go back to plain old ordinary hand washing, the outcome and the effects that it has had, it's amazing.
I know it's true. We talked about that right back to Florence Nightingale. It was, the science has been there for a long time, and it still is the most effective means to stop the spread of infection.
Any comments from the other board members? No? Okay.
Thank you.
Thank you. Thank you very much. Okay. Finance report. Chris Henry.
To say a few things
Please.
before Chris
Please.
makes his presentation tonight. The board is about to see some of the most important results of the efforts we've been making in the hospital to control costs and to get our costs down and to reduce our losses. And this has been a long-term effort that has gone on for several years now. And it's beginning to bear fruit. Tonight you'll see that. But before Chris makes his presentation, which is really remarkable and very pleasing, I'd like to thank the management team at the hospital. These are people who have responded to the call, dug deep, found new and safe ways to operate their departments with less. They've committed themselves wholeheartedly to our efforts in lean and are learning those skills with a willing heart and a lot of excitement. They've made a commitment to this institution and have stayed here even though there have been no salary increases for management for 3 years. These salaries in our industry have been going up steadily in other institutions like Kaiser. And I think in the coming years, they're going to give us a run for the money in terms of keeping to our board policy of meeting the market, of which they are such a significant part. But I think that what our management team has done is deserving of board acknowledgement and recognition. These are unselfish people who stayed here and kept their commitment to this hospital because they believe in it and its missions, when they easily could have decamped and gone somewhere else, perhaps for greater pay. I'm really proud of our management team. I think they are a distinctive part of what makes this hospital very strong. So with that, I'm going to give the microphone to Chris, and you will see what some of the remarkable results of everyone's efforts look like.
Thanks, Nancy. So tonight we'll be looking at operational activity and the resulting financials for Washington Hospital for February 2015. Average daily census for the month was 6.8 above the budget at 181.4. Admissions were 34 below budget at 987, but our patient days were 189 above budget at 5,078. Outpatient observation equivalent days for the month were 70 above budget at 259, and our average length of stay came in very close to budget at 4.74. Looking at utilization, case mix index for the month came in lower than we expected into budget at 1.396. So we had a lot of people in the house, just lower acuity, and you see that reflected in the gross revenue. Deliveries came in 2 below budget at 139, above budget at 139. We had 308 surgical cases, 18 below the budget of 326. That included our joint replacement cases that came in 1 above budget at 113, neurosurgical cases that were 10 below budget at 17, and cardiac surgical cases that were 5 above budget at 14. Cath lab procedures for the month came in a little bit above budget at 571. Our outpatient visits for the month were 99 below budget at 7,061. And our emergency room came in 188 visits above the budget at 4,407. Quick look at the cath lab activity. Not a lot of change here at this point. Peripheral vascular procedures continued to be the highest number of procedures performed, followed by cardiac and non-vascular. Looking at productivity, productive FTEs for the month were 36.1 below budget at 1,192. We had 155 non-productive FTEs, giving us total FTEs that were 29.2 below the budget at 3,047.1. And our FTEs per AOB came in 0.5 below budget at 5.51. So the productivity of the staff in February was very high, and people were working very hard to get the job done. Moving into the financials, total patient revenue for the month came in 1.1% below the budget at 162,325, and again, that low acuity is reflected there. Contractuals for the month came in where they've been running the last several months, about 78.54%. Again, that increase there is reflective of the shift between private and Medi-Cal as that Medi-Cal expansion really took root over the last months. giving us net operating revenue about $3 million below budget at $35,224,000. Operating expenses, however, came in $3.123 million below budget at $34,871,000. That variance driven in the area of supplies, driven by lower prosthesis and drug costs. Our purchase services were below budget. We had lower repairs and maintenance and no recruiting costs in the month. And then again, our provision for bad debt and charity shifting up to that contractual line, so that was lower than budget by about $2 million in the month. So we end the month with an operating bottom line very close to budget at $353,000. But you know, the real number to look at is where we're at year to date. Year to date, we expected to be just a little under $2.6 million operating bottom line, and we're running almost $11 million. And at this time last year, we were pretty close to 10 million negative at this point in time. So really a lot of effort being done by the management of this institution, as Nancy mentioned, to get costs under control and to really get us back on track. And March, when Nancy reads her March report, you're really going to see things jump out. So non-operating income for the month, and this is our Governmental Accounting Standards Board presentation, and this is where the change really occurs, is in non-operating. About $497,000 below budget at $580,000. We had a $470,000 unrealized loss on our investment, and that's been flipping back and forth from month to month for months. So I believe it flipped again in March. So the financial markets can't quite decide which way they're going to go with interest rates. So we ended the month with a total bottom line from a GASB perspective of $933,000, about $511,000 below budget. Excuse me, I said for March, that's for February, which is actually a pretty good performance for February. It's a short month and really one of our most challenging months during the year generally. Quick look at our Financial Accounting Standards Board format. This is the way financial markets tend to look at us. Operating bottom line doesn't change at $353,000. We do pull our property tax revenue that supports our general obligation bonds out of there, and we neutralize the unrealized loss on our investments to come up with non-operating income from a FASB perspective of $266,000 and a total bottom line of $619,000. So are there any questions on February? Okay.
I think you're going to like March.
I was dazzled. It was very reassuring. In March, we saw 1,156 patients that were admitted to the hospital. Our average daily census was 185. The average daily census was 22.2 above the budget of 163. The census that was recorded in March was 15% higher than March a year ago. The outpatient observation equivalent days of 270 were higher than the budget of 226 by 44. So control of observation patients and initiation of that observation unit could not be a higher priority for us. We need to get that done. In terms of average length of stay based on discharges for adults and children in March was on budget at 4.86. It was higher than February's average length of stay. The birthing center saw 162 deliveries in March compared to a budget of 154. March deliveries resulted in 343 baby days of care. Our newborns totaled 166, so we had some multiple births in there. By comparison, we had 167 deliveries a year ago in this month. For surgeries in March, we had 407 surgical cases, 53 cases above budget, or a 15% positive variance. This is the highest level of activity we've seen in our operating room since October of 2011. March's activity included cardiac surgical cases that were 3 above budget, neurosurgical cases that were 20% above budget, joint replacement cases that were 25 cases above budget for a 21% positive variance. General surgery cases were above budget by 31, or a 15.5% positive variance. Our inpatient surgical activity was above budget by 41, 14.4. Outpatient surgeries were above budget by 12, or 17.1%. 662 cases were seen at the outpatient surgery center. Their budget had called for 609. For the month of March, total procedures in the cath lab were 852 versus a budget of 615. Cath lab staff all deserve some recognition for this. That's a huge variance. By comparison, the cath lab volume for March of 2014 was 581. It gives you an idea of the order of magnitude. Overall, inpatient cath lab procedures were 31.9% more than anticipated, and the outpatient procedures were 45.4% more than budgeted. Cardiac procedures were 41 in number above budget, or a 27.7% positive variance, and peripheral vascular procedures came in at 50% above budget. Neurointervention procedures were 12 above budget. That's a 75% positive variance, and those are very in-depth cases that take up a lot of time and resources in the cath lab. Those are not simple things. Non-vascular interventional radiology procedures were 27 cases higher than budget for a 39.7% positive variance. Non-emergency outpatient visits for March totaled 7,946. They were 119 higher than the budget and slightly lower than March a year ago. The emergency room and clinics recorded a total of 4,867 patients, a daily average of 157. This was 531 above budget, or a 12.2% positive variance, and above March visits a year ago by about 386. The Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 4,302 patients during March, 154 cases more than budgeted. The total system emergency room and clinic visits for March were 9,169 compared to a budget of 8,484. Full-time equivalents for the month of March totaled 1,364.0, including 15.4% agency personnel. This was 51.8 higher than called for in the budget. Productive FTEs were above budget by 4.2 for the month. Non-productive FTEs came in about 9.3 FTEs above budget. The higher number of employees is a direct reflection of the challenges this new volume brought us. Patient mix, inpatient revenue for the month of March amounted to approximately $149.5 million compared to a budget estimate of $131.5 million. Of this amount, 57.7% was Medicare, including Medicare HMO. 17% was Medi-Cal, including Medi-Cal HMO. This compares with the budgeted inpatient revenue percentages of 57.6 for Medicare and 16.8 for Medi-Cal. Our total government program revenue for March was 74.7% of total inpatient revenue. We had budgeted 74.4. Pretty close on spot. Based on March's 5,725 patient days, 58% were Medicare, 18.3 were Medi-Cal, so this is patient days. And this compares with the budgeted percentages of 56.5 and 18.9. In terms of revenue for the month, we came in $18 million above budget, or a 13.7% positive variance. Outpatient revenue for March was above budget by $7.8 million. That's an 18.6% positive variance. The inpatient revenue variance is driven by higher levels of activity in the OR and cath lab and associated ancillary services. Outpatient revenue was higher than budget primarily due to the increased outpatient activity in the OR, the cath lab, and our emergency room. In summary, we had 117 more admissions and 686 more inpatient days than we had anticipated in the budget. Our surgical cases were above budget by 15%. Cath lab procedures were above budget by 38.5%. Outpatient visits for March were 1.5% above budget. ER visits were 12.2% higher than anticipated. Clinic visits for the month were above budget by 3.7%. Total paid FTEs were above budget by 3.9%, and above the last 12 months average by 41.8 FTEs. Our FTEs per adjusted occupied bed, however, were below budget. Inpatient charges for the month were above budget by approximately $18 million for a 13.7% positive variance. Outpatient charges were higher than the budget by approximately 18.6%, or $7.8 million. Total hospital charges for March were above budget by approximately $25.8 million, for a positive variance of 14.9%. On March 31st, there were 186 days cash on hand, up from 178 in February. The total days revenue and accounts receivable at March 31st was 60.23. The days revenue and accounts receivable excluding Medi-Cal was 58.27. Days and accounts receivable excluding the Alameda Alliance, which remains an ongoing problem for our institution as many others, is 57.85. So you can see what a drag on our accounts receivable this has become. During the month of March, $1,035,016 of charges were approved or pending for charity assistance. On the strength of this performance, I have released the freeze on management salaries, and we will be reviewing their ranges to make sure that they're current with the board's policy of meeting the market. So that process is already underway at my direction. But I am very proud of the staff that have worked so hard to get us here. It's my intention we'll hang on to results like this and move forward with the objective of becoming the highest quality, low-cost provider we can be. That's the agenda for this hospital. And the management team is helping us get there. And it's been a rugged 2 or 3 years, and they deserve commendation for their loyalty and their diligence.
Very good. Thank you, Nancy. Thank you to the staff, too. Good numbers, Chris. Keep it up. Thank you. We have two action items requiring a motion.
Item A, Madam President, in accordance with district law policies and procedures, I move for approval of the Medical Executive Committee proposed nurse midwife privilege form.
Do we have a second? Second. Dr. Lunny, would you like to elaborate on that, where we're going with this?
Yes, we've added nurse midwives as one of our allied health providers at the hospital, and in order to have them see patients and do what they do here in the hospital, they need a list of privileges that we can grant them, monitor their competence with, and allow them to take care of patients. So that's what this privilege form delineates.
Thank you. This is kind of history-making in a way, because you don't normally see this in a hospital. So this is This is very impressive. Thank you.
Sort of modern medicine in terms of trying to use allied health providers to
Right.
to take care of patients.
Take care of our
yeah.
patients, yes. Okay, thank you. Christine, would you call for a roll call for the vote, please?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Motion passes, thank you. Our second motion, please?
Item B, Madam President, in accordance with district law, policies, and procedures, I move for approval of the Medical Executive Committee proposed nurse practitioner surgery privilege form.
We have a motion and a second. Dr. Lunny, would you mind going over this one again too, please?
Yeah, similarly to the nurse midwives, we've added nurse practitioners to our medical staff as allied health providers and physician extenders, if you will. And last month we had privileges added for critical care and medicine for the nurse practitioners to participate with. And this month we've added surgery privileges and delineated all the particular privileges that our nurse practitioners will be engaging in to care for patients at Washington Hospital.
Okay, thank you, thank you. Christine, would you do a roll call for vote, please?
Director Danielson?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Motion passes, thank you. The board will now adjourn to a closed session, thank you. We are back in open session, and I would like to report that there was no reportable action taken during our closed session. With that, this meeting is adjourned.